Good afternoon, everyone. I'm Don Wiley, President and CEO here at St. Joseph's Medical Center, and I want to welcome you to our third community update. Today we're going to have another update from Dr. Scott Neeley, our Chief Medical Officer, and our DIO for our residency training program, and Tammy Shaff, the Director of Community Health for Dignity Health St. Joseph's Medical Center here in Stockton and the county. Natalie, if you'll advance the slide, please. This is going to be our agenda for today. I'm going to give a very quick update, and we hope to have about 30 minutes of presentation material, maybe 35 with me, and leave time for question and answer today. I know a lot of you have questions, and we actually have had several questions submitted to us in advance. Natalie, you're going to start with the reflection?
I certainly will. This reflection is by Henry Ford, and it says, "Coming together is the beginning, keeping together is progress, working together is success." And I think that's definitely what we need during this pandemic.
Thank you very much. And if you'll advance the next slide, I'd really appreciate it. As of yesterday, the ICU usage in our county was still at 111% of ICU capacity. And that's even though we don't have very many COVID positive patients in our ICUs. In my case, for St. Joseph's Medical Center, Scott will give you today's numbers, but I believe yesterday we had some 10 patients that were COVID positive in our ICUs, and we were over our ICU capacity. So we still have a lot of patients who are requiring intensive care unrelated to COVID disease, and I wanted to be sure that I said that as we started today. Just to give you an idea about hospital volumes and operations, our census actually has been exceeding our budget. We are currently sitting at 337 inpatients this morning in our 355 beds, which means we're holding patients in our EA this morning as we started the day. That's not uncommon. We've been around 300 for a while. This week we've averaged about 230 emergency department patients. That's about what we were the last time we talked to you 7 weeks ago. Now, I would say 7 weeks ago, we had about 100 COVID positive patients in the hospital. We had a peak on July 27th of 115 COVID positive patients in the hospital. Today, Scott will give you those numbers. Yesterday, we had 19 COVID positive patients in the hospital, 10 of whom were in the ICU, 7 of whom were on ventilators. And again, Scott will give you the updated, more detailed information. Otherwise, we talked last time about restarting procedures, not so elective, but needed procedures. During this month that we're in right now and last month, we were about 85% of our regular budgeted numbers for surgery, GI, interventional radiology, and cardiac cath lab. This month, the cath lab looks like it's going to exceed its budget, and our maternity department is going to be right on budget. So volumes are close to normal. Inpatient volumes are actually high. But that's also normal. One thing that we are suffering a little bit is a longer length of stay for all patients. Obviously, COVID positive patients had a longer length of stay, but we're seeing that in a lot of patient categories currently. And I think it's because people are deferring care. We talked about this before. We don't think it's a good idea. If you need to see the doctor, go see the doctor. And most of our physicians are seeing patients now and or can be seen virtually. That way, if you need to be seen at the hospital or seen by a specialist, you can be seen. We're continuing to require masks for everyone who's working here and everyone who's coming into the hospital. We have a terrific supply of PPE at this time, and we continue to follow the CDC guidelines and then some. We continue to test all inpatients now, and we continue to test all patients coming in for a procedure of any kind. So our testing capacity has also been very good, and you'll see later when we talk about some of the things that are going on in our county that there's more and more test capability in our community. And again, we're continuing to have visitor restrictions as directed by the county public health, and our county is still purple. Scott will talk about that when he comes on during his presentation. And then just a quick update on a Mask On campaign that we co-sponsored with United Way and San Joaquin Public Health as a way of getting the message out in multiple languages to our community that those simple things we talked about last time, the time before, and that we talk about every day in our update with our employees: wear a mask, wash your hands, don't touch your face, socially distance, stay away from large crowds, and if you have symptoms, stay home for sure. Should stay home as much as you can anyway, but if you have symptoms, stay home. And I can't leave my introduction without really thanking all of our dedicated staff for their hard work and resilience. On July 27th, we had the most COVID positive patients of any common spirit health hospital in the country. There's 140 hospitals in 22 states. And I'm really proud of what we were able to accomplish working together with our medical staff. And I'm really happy that we are sitting at that 20-ish number as of today. Next slide, Natalie. So Dr. Neeley, as I introduced earlier, Dr. Neeley is a board certified critical care doctor, pulmonologist, and also palliative care doctor. He is not only leads our clinical work here along with our nursing leader, Ray Cheris, but also leads our residency programs. And it's my pleasure to introduce Scott Neeley.
Good afternoon. Thank you, Don. And I'm going to switch over to my slides, which should be right here. You should be seeing my slides now. Natalie or Don, if you could let me know if there's any problems with my sharing, but it looks good to
Dr.
me. So,
Neeley.
Okay. I actually had a reflection of my own that I wanted to share with you because I think that, in sharing clinical information, scientific information, there's just so much confusion and hand-wringing and heartache going on right now as we navigate through this unprecedented, really historical event. I just felt it was wonderful to share these words from a high school student on his view of the future, his optimism, his hope, and at the same time, his hope that that we're paying attention to the scientists, to the physicians, to the people in our communities who are trying to provide us with safety and lead us out of this. And so by having faith that this virus will pass, listening to the medical professionals and authorities, staying indoors, keeping good hygiene, social distancing, not giving into fear mongering, and being mindful and supportive for those deeply affected, either physically or emotionally, I wholeheartedly believe that we'll be able to persevere and come out stronger. Good way to start, and I agree with Jack. So this is where we are right now in San Joaquin County. The state of California and the governor released a new plan for safe reopening. and put counties into 4 different classifications in terms of the current impact of COVID-19 in those counties. In San Joaquin, we're still purple, which means widespread, and I'll go into that in a little more detail. We have 8.8 new cases per 100,000 population daily. That's our current average. And a 7.1% positivity rate for people who are being tested. And I'll talk a little bit more about positivity rate. These are the 4 levels in the blueprint for a safer economy in California, and it helps to explain why San Joaquin County is still at the widespread level, because we're above 7 new cases per 100,000 population, though we have dropped below 8% in terms of our positive testing. This is a lot of information, and I am going to go through the slides quickly, but I want to point out a couple of things. Number one, just the magnitude of the pandemic for our county. We've been as hard hit as any county in California, and at times we've certainly been one of the most hard hit places in the United States. At the same time, while we've suffered nearly 400 deaths, and we probably have exceeded that number by now, we can see in the middle graph that the number of cases on a weekly basis is starting to decrease. That's very hopeful. You can also see the type of impact this has had, and what this shows us is that in terms of the actual number of cases or percentage of people who've been affected, the group between the ages of 18 and 50 have actually seen the majority of the cases reported in the county, but a vast majority of the deaths reported in the county have been for patients above the age of 65. This part of the graph shows the number of deaths by week, so you can see we were hit hard, and this really did impact our neighbors, our friends, our families, and loved ones. And as you can see, in early August, we were actually seeing over 60 mortalities a week due to COVID-19 virus in our county. And again, that is a very, very heavy burden for our community, and we're very grateful to see those numbers decreasing. This shows the impact in terms of COVID-19 inpatients or hospitalized patients. Perhaps less than 20% of people who actually develop COVID-19 need to be hospitalized, but you can see that around the beginning of June, the number of hospitalized patients with COVID-19 disease began to sharply increase. That occurred after our sort of spring holidays. We think it really began with Mother's Day, but then it certainly accelerated with the Memorial Day weekend and the 4th of July. And you can see that by the end of July, we had over 250 inpatients with COVID-19 disease in our county hospitals. And we had in excess of 80 ICU patients in the county at our peak. This represented a very significant percentage of our county hospital and ICU capacity. And at that time, our ICUs were substantially over full. And as Mr. Wiley already mentioned, we continue to have very high ICU utilization in the county. But fortunately, the number of COVID patients taking up those beds has gone down substantially, as you can see by looking at the red line. And we had a little over 40 ICU patients in our county due to COVID disease yesterday. And this just shows the overall county hospital bed utilization. You can see we're below our licensed bed capacity and have remained that way. But we significantly exceeded our ICU capacity during the peak of this, and we're still a little bit above our ICU capacity in the county right now. So the impact has been substantial, and it's not only an impact caused by COVID disease, but it's an impact of those patients stretching our resources and making it more challenging for us to care for the patients who have other types of medical needs. And that's been something that we've worked hard to navigate, both taking care of the patients with COVID, a challenging and very demanding patient population, but also keeping people safe who have other medical needs and making sure that we have the capacity and the resources to take care of them. Current community prevalence, we have done a study at St. Joe's looking at the current prevalence of infection in the community. We have a very good antibody test, which detects whether somebody has had an infection in the recent past. It doesn't necessarily detect current infection, but it can test whether somebody has had an infection in the recent past. And we tested nearly 2,000 individuals between June and August. I'm sharing this information for the first time with those of you on this Zoom call today. We tested over 1,300 healthcare workers, including nurses, physicians, respiratory therapists, and other individuals exposed to patients. And we found that the incidence of positive antibodies in that group was 4.1%. We also tested a large group of community members who did not have healthcare exposure. And interestingly, their incidence of antibody positivity was higher than the healthcare workers group. This is preliminary results. I just wanted to sort of share this with you to give you an idea of what the prevalence is in our community right now, resting around 5% of the population having been exposed, at least according to this sample size. It right now appears that being a healthcare worker does not actually increase your risk of having been exposed or been infected with the COVID virus, probably reflecting the fact that there has been widespread community transmission, and you're just as likely to be exposed to the COVID virus in our community as you are at St. Joe's, where we're taking actually exceptional precautions to keep the environment safe and to prevent transmission within the organization. Now, this is a busy scorecard. It shows a tremendous amount of information, but I want to point out that we've taken care of over 800 unique patients with COVID disease at our hospital, and we've seen 177 mortalities, just emphasizing the terrible toll that this pandemic is taking in our community as it is in communities across the country. That's about a 21% mortality rate. And that is very consistent with what's been reported in the medical literature. In many ways, our county strongly reflects what's seen in other counties that have been impacted by the disease, and the outcomes for our patients have been very similar to what's been seen in other areas that have been very hard hit by the virus. You can see that we've actually discharged well over 600 patients to home and to chronic care facilities. In our county, the overwhelming mode of transmission is community. In other words, we don't have large breakouts in institutions. It's mostly community transmission. The age distribution for hospitalized patients is a little bit different from what we reported in the county as a whole, because older people are more severely hit by the virus, and so you can see that a significant majority of our patients who've been hospitalized have been over the age of 60. The distribution of race and ethnicity for our hospitalized patients largely reflects the makeup of the county, and similar to other parts of the country, minorities, and in our case, particularly Hispanic people, have been harder hit than some other groups. This is a graph that shows our average daily admissions. And so you can see that, again, the good news is reflected here. The blue bars reflect the admissions on any given day. So you can see that we topped out at 22 admissions one day in late July. And then the orange line shows the running 7-day average for admissions to the hospital for COVID-19 disease. So again, that very rapid run up in July. And then as we moved into August, we began to see a decrease in the daily admissions. This very much reflects the fact that the county essentially closed again, that we went back to strong distancing methods, that we closed indoor gathering places. And when we went back to taking this seriously and practicing masking and physical distancing, we saw the number of cases begin to decrease in the county, just really demonstrating how effective these methods can be when we actually use them. It comes at a cost, but it does work and it does save lives. And this graph demonstrates that fact from another point of view. And what this is our positivity rate for testing. So these are all tests performed in our laboratory. Now, we do a lot of testing at St. Joe's because we're a reference laboratory, and we do testing for hospitals all over Central and Northern California. So you can see that some days we test close to 800 specimens a day. During the peak of the recent activity in July, we're seeing over 20% of our samples actually testing positive for the virus. That is a very, very high positive rate. That demonstrates very widespread community transmission. And again, you can see that as we closed indoor meeting places, as we saw higher utilization of masking in the county, that positivity rate dropped. We're now seeing days where we're below 5% for our positivity rate. That's very encouraging and a demonstration of how effective we can be when we're practicing safety.
Scott, if I could,
I'm going to talk a little, yeah.
if you go back to that slide, at that peak, a lot of those specimens are not from our county, but they were from other counties that were hotspots because we were getting tests from hospitals as they were having trouble getting tests turned around in places like San Bernardino and Los Angeles during that period of time at the peak. So probably more of the tests now also are reflective of our county rate because we're not getting quite as many out-of-county test volumes.
Great, thank you for the clarification. That is correct. I'm going to talk a little bit about treatments. We have utilized 3 treatments primarily for COVID disease at St. Joe's. Recently, a study was released looking at convalescent plasma. That is plasma that's obtained from patients who have been previously affected with the COVID virus, the SARS-CoV-2 virus, and who have antibodies against the virus. We transfuse that plasma into our acutely infected patients. A study came out from the Mayo Clinic Registry, which we participated in, which suggested that this treatment may indeed be helpful in patients with COVID disease. Patients who were treated earlier in the course of their illness with convalescent plasma did better, and patients who had higher titers of the neutralizing antibodies in the convalescent plasma also did better, which provided some suggestion that the treatment may help. Now, this is not strong data, and there's been a lot of controversy in the news about it. What we can say right now is that we think that the treatment may be helpful. We think that it's relatively safe. And given that there aren't other highly effective treatments, we've used it very substantially at St. Joe's, and this reflects our experience. We've treated over 350, so far I think treated about 375 patients with convalescent plasma at St. Joe's. We were participating in the Mayo Clinic convalescent plasma and COVID-19 study. And what we saw amongst our patients was a mortality rate of about 14.6% for the treated patients. Now, That mortality rate is interesting. It's not statistically significant, and it's not compared against a control population of people not treated with the plasma. So we don't know, based on our own experience, whether we're really seeing an impact of the treatment, but this is our experience. We wanted you to know that we are utilizing this treatment. And we adopted it very early in the course of the pandemic and have used it quite heavily. Another treatment that has gotten a lot of press is remdesivir. It's an antiviral drug which was actually developed as a hopeful treatment for Ebola. It doesn't work for Ebola, but it was tested against COVID disease, and there's a lot of data on this slide. What I'm going to boil it down to is that in the studies that have been released, remdesivir seems to have a mild benefit for patients with relatively mild disease. It's not effective for patients once they've developed severe disease and require mechanical ventilation, but it does seem to perhaps have some activity against the virus for people with mild disease, and those patients had shorter hospitalizations and a trend towards better recovery in the study that has been released. We have treated 129 patients with remdesivir at St. Joe's. We've had relatively good access to the drug since it became available. We've had 86 patients discharged home after treatment with remdesivir. That's 68%. 28% of the patients who were treated with remdesivir actually expired in the hospital. That's a little bit higher than our average, but we think that patients treated with remdesivir were probably on average a little bit sicker to begin with. We, again, cannot draw any big conclusions from this. I think that those of us who've cared for patients would say that, we're hopeful that this has some impact, but it certainly is not a dramatically effective treatment. The final treatment that we have used is dexamethasone. That is a steroid drug, which interestingly doesn't have any antiviral activity, but it may modulate the body's immune response to the viral infection, and may therefore result in less inflammation, less damage to the lungs and other organs in people who are infected. This actually seems to be probably the most effective treatment that we have right now, but again, it is not a dramatically effective treatment. It does seem to improve survival in all types of patients, whether they have mild disease to begin with, or whether they are severely ill. And in this study, even the patients who were on mechanical ventilation saw a substantial improvement in mortality rates, which is something that's not seen for the other treatments that we've talked about. I want to talk just a little bit about what we've learned. The number one thing that we've learned that this is not influenza. I've been a pulmonologist for over 30 years. And those of us who take care of patients with lung disease, who take care of critically ill patients, have not seen anything like this in our careers. It's a devastating illness. It has an incredible range of clinical presentations, given that over 80% of people who are infected with the disease have mild or asymptomatic disease. But when it's severe, it is very, very severe. And patients who are sick enough to be admitted to the hospital have over a 20% mortality rate. That's not something that's seen with any other disease process that we take care of. And it is truly a devastating illness, and I don't want anybody to leave this seminar with any other understanding than that. It preys particularly on people with underlying health conditions such as diabetes, heart disease, high blood pressure, and obesity, and it preys on the elderly. Current treatments are only marginally effective, and I've given you a little bit of information about that. We've worked hard to implement those treatments at St. Joe's, but we know that they have at best a mild impact on the outcome of the disease. And the most important thing that we can all do now is prevent the spread of the disease and minimize the number of people who actually become infected. What we've accomplished so far is something that we're actually extremely proud of. We've taken care of over 40% of the acutely ill COVID-19 patients in San Joaquin County, probably the largest number of COVID patients in Northern California. And as Don said, in our 140 hospital system, there were several weeks where we had more COVID-19 patients hospitalized than any other hospital in our national system. We have rapidly implemented state-of-the-art care at St. Joe's in our ICU, adopting new ventilation techniques, adopting new medications and investigational treatments, and doing very rapid education of our nurses, our physicians, our respiratory therapists, and other frontline providers as knowledge about how to treat this disease came out. We expanded from 39 to 70 ICU beds. We had an entire ward normally used for non-ICU patients converted to an ICU, and we converted beds in our emergency department to ICU beds. We used innovative staffing approaches, and we saw exceptional leadership from our physicians, our nurses, and other providers. As difficult as this has been for so many people in our community, we're exceptionally proud of our staff and our physicians who have met a challenge that really was as great as any seen in the country in terms of the impact of this disease on our hospital and on the patients that we care for. One of the questions that came in as we prepared for this presentation was about herd immunity. Unfortunately, even physician leaders in our country are promoting this concept that spread of the infection might not be so bad because it will promote herd immunity. And I wanted to talk a little bit about that because it's actually a very dangerous idea, and there is some very poorly thought out misinformation being put out about this concept. So we wanted to talk to you about this today. Now, herd immunity occurs when large parts of the population have achieved immunity to a viral illness, such as COVID-19. It happens through two mechanisms. You either get a vaccination or you have natural infection of large portions of the population. Will herd immunity protect us? One of the important things that you need to understand is we don't know. A case in point is influenza. Nearly all of us have either had influenza infection or vaccination, and we still need a new vaccination every year because the virus mutates. And while we develop herd immunity to some strains of influenza, a new one comes along, and we have to continuously go through the cycle of exposure and vaccination. So the idea that herd immunity is somehow going to stop this pandemic by everybody getting infected is not something that's been proven. It's something we just don't know the answer to. But more important is understanding what the impact of natural herd immunity would be if it were to actually occur. Because 70% of the population would have to become infected with the virus in order for natural herd immunity to occur. And when you do the math, even assuming a very, very conservative mortality rate for the virus, that would mean 2 million deaths. Now, we're approaching 200,000 deaths for COVID-19 in this country right now. We've had the worst performance of any industrialized nation in the world in terms of preventing this illness and taking care of our population. But I'm sure that the number 2 million in terms of significance is not lost on anybody. This is not something that we should be advocating or pursuing. And I want to just share with you a letter that came out from physicians at Stanford. One of the physicians who has gained some publicity about this concept of herd immunity, positions himself as a Stanford physician. He's not. He was formerly a radiologist at Stanford. He has no expertise in infectious disease or epidemiology, and he is not a faculty member at Stanford. And the faculty at Stanford felt it was very important to come out with public guidance regarding this whole concept of herd immunity, because it's a dangerous idea. It would increase mortality spectacularly and in a tragic way in this country, were it be something that we pursued, and it is something that the faculty at Stanford, one of the premier medical schools in the world, wanted to come out to strongly oppose and to point out that this is a fallacious idea and a very dangerous one. And when they came out with this letter, they proposed that we do exactly what public health experts are advocating, which is physical distancing, wearing a mask, using good hygiene, and pursuing vaccination and hopefully other treatments that will be more effective in treating this disease than the treatments that we've had thus far. It's all about taking care of each other and being safe together. There was one of the questions were, should we be doing something else? The fact is that if we do what we know how to do, which is to wear a mask, which is to physical distance, which is to use good hand hygiene and other types of hygiene, we can actually drive this disease down to minimal or even zero transmission. If we all do it together, we can keep each other safe. Continuing to slow the spread of this disease is vital because it's going to save lives, because it's going to allow us to reopen our commerce and to reopen our educational systems, and it's going to preserve the functionality of our healthcare system and protect healthcare workers. So it's all about working together. It's all about being safe together. And it's all about making sure that we can take care of not only people who are infected with this disease, but everybody who needs healthcare, everybody who needs our healthcare resources. I'll have an opportunity to answer questions later. I went a little longer than I was supposed to, but I really want to thank you for attending today and for listening to this information. Our purpose at St. Joe's is exceptional care with dignity and human kindness. And I think that's an approach that we can all get behind. I want to thank you very much.
Thank you very much, Dr. Neeley. Natalie, I'm sure you're going to turn the slides over to Tammy, and I'd just like to introduce Tammy Shaff, who's our Director of Community Health here at St. Joseph's. We stole Tammy several years ago from Sutter Health, where she did a similar job there. And she is just really has terrific connections in our county and works well with just everyone in the public health and community health and homeless network here in our county. So Tammy, please take it away.
Sorry, I had to unmute myself. Hi, everyone. Just making sure, is the slide deck up and operating? Can everyone see the slides?
Yes, we do.
Yes.
Okay, perfect. Give me just a second. Okay, so good afternoon, everyone. I'm just going to take about 10 minutes of your time today to really highlight some of the activities that our community health department has been working on over the last several months, as well as to kind of highlight some of the needs that our community continues to have as it relates to COVID-19. So our vision is to really address the needs of the most vulnerable, and we can't do this without the collaboration of the many incredible partners that we have. So I really want to give a quick shout out and thanks to all of the health and community organizations that either support our efforts or allow us to support theirs. And several of these efforts will be highlighted today. So I'm going to start with 3 projects that are a direct response to COVID-19, Project Room Key, COVID House, and the Mask On campaign. So in March of this year, the governor announced funding would be available to relieve the overcrowding and risk of infection spread in homeless shelters by relocating individuals from those shelters that don't have COVID, but do have high-risk conditions that make them more vulnerable to the effects of COVID-19 than the general population. So I'm really happy to report the city of Stockton, San Joaquin County, the continuum of care for our county all responded really quickly to help identify and contract with a local motel. And our human services agency, county clinic and healthcare services staff, community medical centers, as well as many other partners, including our homeless services providers, all worked closely together to help us identify and place high-risk patients and community members into a local motel. So this not only helps us to prevent the high-risk individuals of getting COVID, but it also helps us to relieve pressure on our hospitals. As an added benefit, having these people in a setting where they can actually receive services on an ongoing basis and support is also leading to additional positive outcomes, such as transition into some permanent housing. So it's very exciting. Okay, so Gospel Center Rescue Mission's recuperative care program, which supports patients that are experiencing homelessness upon discharge from a hospital stay, has had tremendous results since 2013. And they provide a safe place for patients to recover from injury or illness, and they provide case management services to help those patients into housing or recovery or other social service programs that provide long-term outcomes. So it was really no surprise that when we started seeing homeless COVID positive patients, the mission once again stepped up to reallocate 2 of the buildings on their campus into space that is needed for those individuals recovering from COVID so that they are isolated to prevent its spread. Oops, apologies there. All right, so over the last few months, as you can see, 105 COVID positive individuals experiencing homelessness have received shelter, food, hygiene, and clothing, once again in collaboration with the Project Room Key partners. So although incredible work has been done to help our homeless community in regards to COVID, we really do continue to work hard to prevent and reduce homelessness in general. In 2019, when Dignity Health and Catholic Health Initiatives merged to create Common Spirit Health nationally, we also created a Homeless Health Initiative Fund, or HHI, in California, which provides millions of dollars in funding for projects that support homeless prevention and intervention along the continuum of care. So I'm happy to report that our county has already benefited from these funds. Recently, $1.8 million grant was provided to Stocktonians Taking Action to Neutralize Drugs, or STAND, in partnership with our county's Whole Person Care program to develop 7 housing units that can provide permanent housing to a minimum of 16 homeless individuals that are receiving supportive services through the Whole Person Care program. Additionally, HHI funds are also supporting 3 new social workers in our emergency department to solely work with patients experiencing homelessness to get them connected to the resources and the care that they need to support an exit from homelessness. And there are 2 new local projects supported through HHI funds that I'm really excited about. They include the supporting our local Salvation Army with a 2-person street outreach team in our county that will provide case management on the streets and in encampments. And then we also have a new, the newly approved project, Home Key Town Center Studios, which is in partnership with Central Valley Low Income Housing Corporation, or CIVLIC, Dignity Health, STAND, the City of Stockton, the Chan Zuckerberg Initiative, and the State of California. And this is to convert an existing motel into 39 studio apartments that can provide housing for up to 41 individuals. And this is permanent supportive housing. They'll be linked to ongoing wraparound services, really to prevent the returns to homelessness. And CIVLIC has a housing retention and positive housing exit rate of 98% for their current projects. So I really have no doubt that this one will be just as successful. So moving on to what Don mentioned earlier, the Mask On campaign. Since the science shows that masking is essential in preventing the spread of COVID, and we want our community to mask on, not only for themselves, but to ensure that those that are at high risk of negative health outcomes with COVID don't get it. We partnered with United Way and San Joaquin County Public Health Services for the Mask On campaign. So we started with social media campaign organized by United Way, in which local community members showed who they mask on for. So as you can see in this slide, I mask on for my mom, and Don is masking on for practicing kindness. So when we then worked closely with Dr. Park, who obtained some CARES Act funding to order supplies to make 100,000 masking kits. And these kits include a reusable face covering, hand sanitizer, and educational materials on how to take care of the mask and actually how to wear them properly. We have rallied almost 120 volunteers over the last few months to help assemble 70,000 masks. So really exciting. Thank you so much to all the volunteers so far who have helped us with this effort. And we really can't thank our community partners enough for helping us to get these kits out countywide. So to date, you can see we've distributed 59,000 of those kits to 80 different organizations for them to distribute to their clients or to the community through outreach events. So as you can see, there's really been a lot of great work in our community, and this is a very small snapshot of what we and our community partners have been up to. But COVID-19 has not just taken a toll on the physical health of the community, but also taken an economic toll, as Dr. Neeley mentioned, that has led to an incredible increase in needs for food, housing, and other resources. And we know this because our local 211, which has been operated by Family Resource and Referral Center for the last 5 years to provide referrals to local resources, has seen a massive increase in requests for food and shelter resources, receiving about 4 times the number of calls, texts, and emails for assistance. As a quick note, for any of you that may belong to a faith or community organization that are supporting the community with food distribution of any kind, please make sure you contact the staff at 211 so that they can add your information to the database so that it is given when people need resources. And just a quick slide to show that, as you can see, the call volume between January of this year and July of this year increased by a staggering 10 times from 812 to the 8,585 calls per month. So just goes to show again the need that our community has right now. So as many in our community face job losses, leading to an unemployment rate of 14.8%, I believe it was, as of July, we really see the strain on families that are struggling to get enough to eat, to pay the rent, the mortgage, utilities, as well as the medications they need to stay healthy. Although these needs have certainly been worsened by the pandemic, they are not new to our community. So Dignity Health and 8 other funding partners that are listed on this slide have joined together to develop the Connected Community Network, or CCN, which provides the ability for us to send electronic referrals for patients or clients to community-based organizations that can not only support them with resources to address these needs, but also provide a feedback loop to track the outcomes of the referrals, so we know what actually happened to these individuals. So to date, we have 42 sorry about that. We haven't updated this yet, but there are actually 42 community organizations on the network now, representing 94 programs and growing. So it's growing very quickly. They can send and receive referrals from other organizations as well as interagency program referrals, so that individuals that are part of the network have a coordinated care network in the community that can support their complex needs for them and their families. So for more information on how to become a funding partner or service provider on the network, please contact Amy Farrell at United Way. Her information is listed on this slide. So I know I've provided a lot of information in a very quick period of time, but if there are just 2 things that I really would like for everyone to take away from this presentation, is that there is a lot of great work happening in our community. I just barely touched it. And I think it takes all of us working together to make a difference. Our community organizations have been hit hard with the increased need for those they serve without the ability to do things like regular fundraising events to keep them operating. So that, of course, they need funding, but they also need volunteers to support the increased need. As an example, Emergency Food Bank of San Joaquin served over 2,000 more people in July as they did in January, and they need more volunteers to help them with this increased volume. So there's some contacts listed on this slide. If you're interested in volunteering at the food bank, please contact Rebecca Hood. If you are interested in other types of volunteer opportunities, the Stockton Strong is a great way to find those opportunities, as well as United Way for opportunities all across the city and county. And so as Helen Keller said, alone we can do so little, together we can do so much. So it really is going to take all of us to support each other and our community. So thank you for your time today, and please feel free to contact me with any questions. And now I'll turn it over to Don.
Thank you very much. It was a pleasure to have both of you on today, and really a very different presentation than what we had the last two times. So thank you both for that. One of the things I wanted to mention as I'm wrapping up, and we can open it up to questions, is that the county public health is really trying to open up more testing, and they're particularly trying to do it in all zip codes. Access to testing and healthcare disparities is an issue that is coming out of Sacramento as it relates to opening up. And so our public health officer, Dr. Maggie Park, sent out an email to all of us, and there's a website, www.sjready.org, where you can find more testing resources, and we're going to be pushing out more testing to vulnerable populations so that we can, in fact, reopen our economy. The other thing that Maggie mentioned yesterday on our EMS call was that the county qualifies currently to open up schools based upon the request of either superintendents or representatives of private schools, and then she is providing a waiver. And so she, I think, told the Board of Supervisors she's issued some 10 or 11 waivers already, and will be considering more through about the 18th of this month. So it looks like, at least for K through 6, that there'll be some opening of schools. It'll be interesting to see what happens with the activity in terms of positivity of COVID, but that's an update from Maggie's office. Testing, more testing for people who are asymptomatic. You know, that's been a problem up until now. We have required a referral usually for our testing, either for a preoperative situation or a physician order for a patient admitted. But I think as we go forward, the idea for our county, at least, to reopen is we're going to have to do more elective testing, which is something that we haven't done too much of. So with that, let me open it up to questions, and I'll let Natalie Pettis lead and direct the questions to the various panelists.
Don, you guys have actually answered some questions that have come up as they've been, you know, from the chat, and you answered the questions that came in advance. So I don't have any new ones at this time.
There was one question, Dr. Neeley, that I saw about when someone is infected with the virus and is positive, for what period of time are they considered infectious? I know that we have certain criteria for returning healthcare workers to work and the precautions that we take, but is there any science behind that that anyone knows of at this point?
It's an excellent question, and I perhaps stayed away from it because the science isn't particularly good. The guidance that is coming out from epidemiologists that we do have, I think, some confidence in, is that for symptomatic patients, once they've cleared their fever and their symptoms, and they are out at least 10 days from their diagnosis. So 3 days of no fever, no symptoms, and 10 days out from the diagnosis, there is relatively good confidence that that person is no longer able to infect others. The problem here comes from the fact that people can shed viral RNA. The virus is based off RNA, an RNA gene. People can continue to shed the viral RNA for perhaps a considerable period of time after they are no longer infectious. So in other words, they're not shedding live virus that can infect other people, but they're continuing to test positive. That makes it confusing and challenging to get really good, accurate information about the infectious risk. And then there is the fact that perhaps as many as 45% of people who are infected are actually asymptomatic. And those people we know are capable of wreaking havoc if they're in a crowd. But we don't have a good science about, what their course is in terms of shedding virus and being able to infect other people because they're so hard to identify in the first place.
Thank you.
That's why universal masking is so important.
Yeah. We had another question about how does widespread testing lower the numbers? And so as healthcare professionals, I think we've taken the position if you're not symptomatic, we're not spending what we would call precious resource of testing to determine whether or not you have an infection or not. There have been some exceptions to that. But when we have tested people who are asymptomatic, like everybody who comes in for a preoperative test, they're already screened out as being asymptomatic. They normally tell the doctor, I haven't had this or that, and our staff asks them as well. And then we test them, and we're getting a positive rate of about 1.6% of patients being tested with a good test. So, the thinking is that if we test more asymptomatic people, we'll lower the overall testing positive in our county, because what's happened so far is mostly, not completely, but mostly folks who are symptomatic are the ones getting tested. As an example, in our ER, even symptomatic patients, unless they're going to get admitted to the hospital historically or discharged to another setting, are not getting tested before they leave our ER because they're not going to do anything different. They're not sick enough to be admitted. And if they're positive, they need to isolate. And if they're negative but have symptoms, they need to isolate. And if they're neither, they should wear a mask and socially distance and wash their hands and do all the same things anyway. And it doesn't end up changing much. There's a question about a false positive rate. And at this point, with the test that we're doing, we think there's a very, very little false positive rate. For the antibody test that we did, it's something like 1 in 1,500 or 350, so it's less than 1%. And I think it's similar for our antigen test. And I think we've
false negatives.
Negative. I think we had one patient that we've been able to document during this entire pandemic that was admitted to the hospital. Is that correct?
Maybe 2 or 3. The false negative rate for our test is exceedingly low. We learned a lot at the beginning of the pandemic about how to do these tests well, we did a lot of sort of back checking to try to detect false negatives, and we ended up concluding that the false negative rate was certainly less than 1%. Positive protein in all people that could cause a positive test. No, that's not something that we've heard of. Are antibody tests readily and easily made available? We have an antibody test that is available and we think it's a very good one. That's the basis of the preliminary data that I shared with you. The issue of what to do with that test is really the big one, because while in certain circumstances an antibody test may give somebody sort of a reassurance, that they're not going to get another infection, we don't actually know that that's the case. And you, for the most part, probably wouldn't do anything radically different on the basis of your antibody test. Certainly in some circumstances where people are living with an immunocompromised person in their household, that information could be useful, and it can be ordered through our laboratory.
Mr. Wiley, I had a hard stop at 1 p.m. And I want to thank everybody for participating. We will have this link available on our website. Scott or Tammy, was there anything to close?
I would just like to thank all of you who took the time, spent your time getting this information and learning together. I think that it is critically important right now that we be sharing accurate information about the impact of this disease, that people understand just how devastating it can be when it gets cranked up in a community. Many people in our community, our neighbors, our friends, our loved ones, have been impacted by this. And us really understanding what's going on is critical. Us all modeling the appropriate behaviors is critical, because together, being safe together, we can drive the transmission of this disease down to zero. And when we do that, we're going to be saving many, many people's lives. And so thank you for being here. Thank you for learning, and please promote the safe practices out in our community for the benefit of all of our neighbors, friends, and loved ones. Thank you.
Thank you.
I would just echo Dr. Neeley's sentiments. I think that, from a community health standpoint, prevention is something we're very focused on, and everything that we've talked about today is really important to prevent the spread of this disease, so that we can be physically healthy and economically healthy, mentally healthy. So thanks everyone for taking time today.
Thank you, Tammy. Thank you everyone for participating. As I said, the link will be available on our website. That's www.stjosephscares.org.